que a beleza que existe é
Bom dia a todos. Hoje é o Intramuros do grupo da obesidade e eu aproveitei a presença do Dr. Stuart Flint no Congresso Internacional de Obesidade, que está acontecendo aqui em São Paulo, no Centro de Convenções Frei Caneca, foi uma honra convidá-lo para uma palestra aqui na Faculdade de Medicina. O Dr. Stuart é professor da Universidade de Leeds, na Grã-Bretanha, com um interesse específico em mudança de comportamento, em estigma relacionado ao peso e discriminação, e ele contribui para políticas de saúde pública em vários países do mundo dirigidas para pessoas com obesidade. O título da palestra é Weight Stigma and Discrimination, Pervasiveness, Impact and Implications. Thank you for accepting the invitation, please.
Okay, lovely. Thank you for inviting me and, of course, accommodating me today. And it's great to be able to come here and talk about this topic, as we were just talking before the session started. It's a topic I'm very passionate about. It's a topic that's over the last few decades, it's risen in terms of the appreciation of how important stigma is, and of course, how stigma is impacting many different parts of our life. So, you know, this is, of course, a topic that is very applied, but of course, you'll know that there's a lot of research evidence that's built much longer than we really think about. It actually dates back to the 1960s at least. But if you look at some of the literature, stigma is very evident in literature that dates back hundreds and hundreds of years. For those of you who are scholars and you've read William Shakespeare, you can actually see weight stigma appearing in some of the texts from Shakespeare himself. But to my talk, so pervasiveness, impact and implications, that's what I'm going to talk to. And hopefully by the end, if you don't already believe that we need to act to change stigma, you will do in the next hour. I always think it's important to set the scene. I've used this, I like this, because I think this is an important place to start. This is really the environment. This is where we are at the moment. This is a quote that I've adapted from Sandro Damio. He was a World Health Organization doctor. He now leads Vic Health in Australia. But this is really what we see in terms of obesity. Around about 2/3, 60%, at least in the UK and certainly across Europe and many countries now, we see 60-odd% of people living with overweight and obesity. Yet the blame seems to be very much with the individual. And that, of course, doesn't make sense. And you see the example given in terms of failure within education. Now, this, of course, isn't a holistic list, but again, I think really important just to highlight how pervasive weight stigma and discrimination is. So many different stereotypes you'll see down the bottom. What I think is really important is highlighting how age relevant these stereotypes are. So when are we exposed to these stereotypes? This is all based on evidence. So research has told us that children as young as 3 years old are reporting stereotypes and stigma towards people with a higher weight status or characters that they see on TV. So they will often revolve around laziness, being slow, or gluttony. When children move into what is primary school or elementary school, so 4 or 5 up to 11, they're exposed to lacking friends, being abnormal, being stupid, unintelligent, clumsy, unhygienic. I think these are critical. We have to think about the developmental phases that children are going through. What's really important for a 4 or 5-year-old children at that stage? It's making friends, it's developing their communication, speaking with different people of different backgrounds, of different genders, of different ages, and so forth. But if they're exposed to this type of information that says that based on your body weight, your body size, you're going to have less friends, you're going to be socially inept, that's critically an issue, and that will impact children at that age. Again, stupid, unintelligent, they're really important developmental phases for young people. And when we move into teenage years, you start to see unattractive, ugly, sloppy, for 15, 16-year-old children being sexually undesirable or being perceived as a failure. Again, critically important for those developmental ages. And then young adulthood, unmotivated, it's your fault, lacking control and non-compliance. So I think this is critically important for us to think about in terms of, one, how pervasive stigma is, two, the likelihood that people internalize these perceptions and these thoughts. And some of the work that we've conducted, and I spoke to yesterday in the Congress, showed that people who are exposed to this type of information critically at teenage years are more likely to internalize those biases. And of course, we know that weight bias internalization is associated with mental health concerns, including depression, lowered self-esteem, and so forth. I've highlighted a few in blue and green. The ones in blue I think are really important. If you speak to people, I'm sure many of you speak to people living with obesity, whether it's in clinical care or other, these are often the ways that they will describe themselves. I feel abnormal. I don't feel the same. I'm being perceived as abnormal. I'm a failure. So many people that I speak to living with obesity, whether it's through research or whether it's through practice, describe themselves as a failure. And if you open the media and other sources, they tell you that obesity is ultimately a failure. It's a failure of willpower. And then, of course, burden. And again, if you look at if you open the news today, I'm sure there's going to be an article on obesity. Probably one of the first lines will say, the burden of obesity. Obesity is a burden on society. People are a burden on society. And when you speak to people, they'll tell you, I don't want to be a burden on society. I don't want to cost the healthcare service. I don't want to cost other people taxes. So it's an issue. I like to talk to misconceptions. Misconceptions, I think, are driving stigma. So a common misconception that you'll be very familiar with is that obesity is simple. We're often told obesity is simply about how much you eat and how much you expend. And whilst that's the final common pathway, there are so many different factors that influence our body shape, size, our weight, and so forth. Hands up if you've seen this diagram before. 1, 2, just 2. Well, it's from the UK, but it's actually globally, it's one of the documents that we often talk to when we talk about how complex obesity is. So this is the Foresight report. It was commissioned by the UK government and published in 2007. And the aim was to identify all of the factors based on evidence that we know are associated with an increased body weight to the point of obesity. So factors that potentially cause obesity. Now, of course, it's small. You can't read all of the different factors, but if you get a chance, have a look at the document. So all of the little squares or circles with words in there, factors. What you also see is lots of lines. It looks like a big plate of spaghetti. But at the end of the lines is little arrows. And what this is showing is the interconnectedness of these factors. So what this is really showing is that obesity is the result of multiple factors. It's not one factor that influences obesity, it's many different factors. And these factors are across different determinants. So there's social determinants, there's economic determinants, there's psychological determinants, and so on. So it's multi-level, it's multifactorial, it's extremely complex. It's not simple, which is ultimately what we're told every single day. It's very complex. And there's not one combination of factors that means that a person is more likely to be living with obesity. The factors that influence my body weight and your body weight are likely to be very different. So again, when we're thinking about the reasons why people may gain weight, but also, of course, interventions, we have to think, how do we start to really understand what's impacting each individual and potentially tailoring or personalizing our approach? What falls out the back of these misconceptions is that everybody can lose weight with enough willpower, because it's all about willpower. It's basically how much you want to lose weight and, again, eating or physical activity. That people are to blame and that people are a failure. And that goes back to the stereotypes I've mentioned. I've also included a definition here from the Royal College of Physicians in 2019 for obesity. And I've included this because when I speak to politicians, when I'm really trying to shift their thought process, I know with politicians, they don't look at obesity every single day, but I have to give them some nudges, some little nuggets of information that they'll take away, they'll remember. So with all of the definitions, they differ slightly, but the consistency is the word chronic, which I've highlighted in bold there, chronic or long-term. Obesity is not something that happens in a week, a few months, probably even a year. It happens over many, many years. So it's chronic. So what doesn't make sense is that we have acute solutions, short-term solutions for a long-term outcome. And virtually every country that we've looked at have short-term weight management programs, for instance, another, which might be 12-week programs. 12 weeks is not going to do anything to the point where we're going to potentially shift the needle with obesity. We need long-term interventions for a long-term outcome. The second misconception is that weight stigma is beneficial. Maybe you've seen this yourselves. I couldn't tell you how many times I've been asked this. I've actually even been asked this in a job interview where I went to another university about 7 or 8 years ago before I joined Leeds. And I was asked, well, actually, isn't weight stigma beneficial? And one of the leading professors said to me, I actively encourage my children to have stigmatizing thoughts because I think that will help them to avoid obesity. And I'm asked this every January because January is, in the UK at least, it's when everybody's making New Year's resolutions. And of course, a lot of people make resolutions around weight management and health. So I'm asked this, and of course, the media has this all the time. These are some of the more recent examples from our media in the UK. But the reality is, of course, from the evidence base, and there's so much evidence now that shows us that experiences of weight stigma are very detrimental. I hope everybody in this room already knows this. But just to really highlight here, it's detrimental. It's across mental health, physical health. So we have increased depression, anxiety, body image disturbance, increased disordered eating behavior, and more weight bias internalization, which I referred to earlier, which is critical, often increases the likelihood that people will experience mental health issues. Physical health, so C-reactive protein levels, increased cardiometabolic risk factors. Of course, that's likely to be associated with the stress process that people go through, an increased likelihood of gaining weight, in fact, and associated with other long-term health conditions. On the third block, it's people's responses. I describe these as maladaptive responses. So it doesn't lead to an increased motivation to want to diet or to be physically active or other, which is the common assumption. It often leads to the opposite. It often leads to avoidance. It leads to disordered behavior in terms of avoiding healthcare, skipping school for younger children. So it leads to quite maladaptive responses. And underneath all this, of course, is that it increases the risk of self-harming and even morality and mortality. I see that my slides aren't quite, oh, they are showing on this one. On the TV screens, it misses off the references. On the references, there's a reference there, Sutton, in 2015. If you have chance and you want to have a look at that article, what they showed there was the experiences of weight stigma, irrespective of somebody's body weight, increased their risk of both self-harming and suicide. So it's not that weight stigma is only impacting people who are in the overweight and obesity range. It impacts people who are in the healthy weight and potentially in the underweight range as well. So weight stigma is clearly an issue. And of course, this then raises questions for us in terms of the effectiveness of policies, healthcare, impacts across all levels, and of course, it may have unintended consequences for individuals and, of course, society. Now, it's really pervasive. I don't have time to talk about all of these. I'm happy to maybe talk a bit more in questions. What I want to focus on is 2 areas, but very briefly, just to say that the home environment is critically important, and there's some key actors there, of course, parents, who in many instances, whilst not intentional, often stigmatize their children and develop and engage in different stereotypes. And this can have an impact, of course, on the eating habits that are developed for younger children, which, of course, then influence them later on. In workplaces, we know that some of the data has showed that people living with obesity are perceived to be less suitable for roles. We've seen in some of the US studies, they've showed that people are paid less for exactly the same job as somebody who has a healthy weight status. So it's an issue in workplaces. Media, of course, is a key space. But healthcare and policies are the key two that I want to focus on for the rest of this presentation. And maybe just finally, before I get there, is just to say that weight stigma, of course, is getting worse. It's not getting better. We've, again, got this kind of perception that because obesity has increased over time, it's become normalized, and therefore that people think that actually we're accepting obesity in our society. It's not the case. Weight stigma has got worse over time. And a quick example of that is a study that was in 1961. It was replicated in 2001, which I'll show you in a minute, but these are the original images. So children in elementary school, they were asked to rank the children they see here based on who they would most want to be friends with, who they'd most want to play with, those types of questions. And you have what is described as a healthy child on the left, child on crutches, wheelchair, amputated hands, facial disfigurements, and then the child with obesity. So what they saw is that the child with obesity was ranked last. They expected the child in the wheelchair to be ranked last, so they actually fell upon this result. It wasn't they were expecting it to be weight stigma. They thought it would be towards the child in the wheelchair. And in 2001, this study was replicated, and the stars on the figure represent a significant change. So what we see here is that the child with obesity still ranked last, but it's significantly worse over 40 years. And the other one I'll just quickly mention is the child with a healthy status significantly increased. And some of the implicit data, so unconscious biases that we have towards people, we've also seen some change. And this is data from Harvard's Project Implicit. So just over 7 million people were included in this study. And they showed that body weight stigma has not changed over the period of time, where we've seen reductions in, for instance, stigma towards people based on sexuality or skin tone and other. This was a report that was published by the All-Party Parliamentary Group in the UK. And this piece of work, they were looking specifically at access to services. Now, that's a critical issue in the UK, but they actually found that stigma was the key findings from this report. And these are three of the key findings here. So most people who were surveyed who were living with obesity reported that they've been stigmatized, criticized, or abused as a direct result of their weight status. And the next two, I think, are really shocking. They're ones that we need to really think about as healthcare professionals. So only 26% of people, only 1 in 4 people living with obesity are treated with dignity and respect from healthcare professionals when seeking advice or treatment. And that's really shocking, because irrespective of why somebody attends a healthcare service or goes to see their doctor, they should always be treated with dignity and respect. And then the second one, 42%, so nearly half of the participants, over 1,000 participants, did not feel comfortable speaking with their GP. This was a study we published in 2020, and this was looking at attitude, stigma, and knowledge amongst healthcare professionals and the general population. We had representative samples from the UK, US, Australia, and New Zealand for the general population. And then we had 1,500 healthcare professionals from 77 countries who responded. The A to E corresponds, of course, with the figure. And the two that I just want to mention in particular is C and D. So what you can see there is, for both healthcare professionals and the general population, that the predominant view is that obesity can be entirely cured by solely a commitment to a healthy lifestyle, which of course doesn't make sense. I've already shown you the complexity of obesity, but also that obesity can be cured entirely by a commitment to a healthy lifestyle. And you can see that differs across the different health conditions that we looked at. Obesity, of course, they're receiving more stigma compared to the other conditions. So there's a lot of change, a lot of things that's happening. You might be aware and familiar with some of these. I would certainly point you towards the Joint International Consensus on Stigma, and I know some of the academics have been very much engaged with this statement, who are from Sao Paulo as well. But certainly I would direct you to some of that. That's really driving change in the way that we're approaching obesity in healthcare. And there is a new commission that is underway with the Lancet that's also looking at this topic. So there is need for change. This has been highlighted in many instances. A short quote from an editorial in the British Journal of GPs in 2019, really highlighting that weight bias itself is a health threat, and that it risks inequality in care, hinders the intervention and adherence efforts of both physicians and patients. So again, there's been this growing focus on this topic that's leading to change. Stigma and discrimination in a healthcare setting, certainly in the UK, it goes against that core value that everybody, irrespective of somebody's background, their ailment or other, should have equal opportunities to access care. And now we even have World Health Organization who are reporting on their reports on obesity, and they have specific publications, and even in their larger pieces that are looking more generally about obesity, they have specific sections looking at addressing stigma, specifically addressing stigma in healthcare professionals. And so there's an example there from the World Health Organization European region, who specifically identified that addressing stigma in healthcare professionals is one of the key targets now across Europe. Just shifting slightly to policy, and I think this is critically important for us to consider as well. Policy inevitably sets the agenda. Politicians, of course, talking about obesity more so, as obesity has become such a key public health topic now. Here's a short clip from the UK, because again, the stigmatizing language and rhetoric is very evident amongst healthcare professionals, but also politicians.
But it's not working, and the government pussyfoots around this. As my noble friend Lord Bacall said, we need to tell people it is not acceptable to be obese. And if you are obese, guess what? Your children think it is acceptable to be obese. So might we have a little bit more of a robust strategy on this?
And of course, we all want a robust strategy, but that robust strategy ultimately needs to be based on evidence. And unfortunately, that's not what we're seeing in the political circles. On the right, you'll see one of millions of examples I could have shown you. What's happened since the Foresight report that I showed you right at the start that showed how complex obesity was. We've evidenced that the political rhetoric and policies that have been developed have become simpler and simpler. It's actually gone away from the evidence. And what we currently have is very much this focus on you as an individual need to take responsibility. You as an individual need to change your body weight, your body size, and so forth. So that's very much the focus in the UK. There's been some really nice publications on this topic, looking at the policies that have been published over this time period. So this is one from colleagues at Cambridge, and they looked at a 30-year period, 28-year period, so nearly 30 years. Outstanding. I mean, you couldn't believe how many policies have been proposed. 689 policies proposed in 20 years relating to obesity. 14 commissioned strategies. So that's one new strategy every 2 years. Remember, I said to you about we need long-term strategies, we need long-term approaches. Every 2 years, we've got a new strategy coming out, apparently. And one of the key issue there, of course, is that these policies, these government efforts are placing the primary responsibility on individual agencies, so individual behavior change. So all of the wider determinants that we're aware of, the environment, whether it's marketing, sugary drinks, all of those types of things that we know are associated, they're not taking steps to address. The other thing that I think is really important here is that weight stigma has become so ingrained in our society that often we're unaware when we're exposed to stigma. And I asked this question, and it came off the back of some work. When I finished my PhD, I ended up doing quite a lot of workshops around London in particular with the government and other healthcare organizations. And I talked to them about stigma. I talked to them about unconscious bias as well. So when people are not consciously aware, but they behave differently to different individuals ultimately. And I had some questions. They say to me, okay, so I might have an unconscious bias. By the definition, I don't know that I've got an unconscious bias. I don't want to be biased. How do I become aware? How do I address it? And so what I used to do, I set up an activity at the start of the workshop. I'd give everybody a newspaper article. There'd be 2 newspaper articles. There'd be 1 newspaper article about obesity, and there'd be 1 newspaper article about cancer. Now, this is not to say that obesity and cancer are the same thing. However, they do share the same determinants. They're genetic, they're social, they're psychological, but it's really for the task. So I would turn to the people who'd had the article on obesity. I say, what do you think about the article? And they would say, it seems to be okay. I'm not sure about some of the evidence that's referenced. Some people who'd seen me speak would say, this is the stigmatizing images that I've talked to before. I would then speak to the people who had the article on cancer. I'd say, what do you think? And there was so much emotion in the room. People were visibly upset. And they would say to me, Stuart, I can't believe this has been published. We need to contact the editor of the Times. This is an absolute disgrace. Then I would say, everybody hold the newspaper articles up. And of course, it dawns on everybody, it's exactly the same newspaper article. And all I'd done was changing the word obesity and cancer, because we know that you cannot talk about people living with cancer in such a disrespectful, dehumanizing way. But with obesity, we don't even pick it up. We just accept that this is fine to talk about people in this manner. And so I've done that with policies. I've done a lot of comparisons of different policies over the years with England, with Scotland, with Denmark, some of the European countries, really thinking about, well, how are they framing obesity and other long-term health conditions? I use cancer because I think that's quite a useful one. There is still stigma in cancer, of course, but we're in a much better place than we are with obesity. So this is a comparison of the long-term plan. This is the current plan that we use in the NHS in England. If you look at the panel on the right, these are some of the differences. So we have cancer. It's discussed positively, reflecting hope and optimism. Hope and optimism, that's critically important. You know that, you're healthcare professionals. People with cancer, they're discussed as survivors. There's positive engagement across a cancer family. So they're part of a family, they're survivors, very positive. Cancer is discussed alongside health conditions. So it's cancer, cardiometabolic risk factors, diabetes, etc. We have person-first language. You'll note that I've been using person-first language throughout, people living with obesity. So it's people living with cancer, that's what's used here. But actually, if it's obesity, what we typically see is non-person first, it's obese people. Could you imagine if it was cancer? Because the comparison here would be cancerous people. And you couldn't imagine, you certainly wouldn't accept anybody saying, this is a cancerous person. You don't describe people like that. People are not defined by their condition. It's person-first language. So certainly we should be using person-first language. And that's what's used in this policy for cancer. Cancer forums, discussion groups, so people living with cancer are then involved in the development of new policies, of new treatments, etc. They're actively involved and their input is appreciated. And then we have obesity, it's very different. And we're talking, it's 12 pages difference in the long-term plan. Obesity is discussed negatively. And what it really reflects is fear and pessimism. What we often see, of course, is that obesity is described as a problem straight away, and you'll see this yourselves. Obesity is a problem. What we often have is that the UK ranks amongst the worst in Europe or across the world. Actually, if you look at the cancer statistics, we have some of the highest prevalence of cancer across the world, but we don't get told that every single day. It's the burden of obesity. Obesity is discussed alongside behaviors. I'm going to show this on the next slide, but what you typically see is obesity with physical inactivity, with smoking, with sexual health. Obesity is not a behavior. It shouldn't be in a behaviors list. It should be in the outcomes list with cancer, with diabetes, and so on. That actually influences our perception of control, because we have personal control over behaviors, and outcomes, of course, are perceived differently. It's individual focus, so individuals need to change. It's condition-first language. So in the same document where we've got people living with cancer, we've got obese people. And there's no indication that patients and the public are involved in any type of healthcare development or policy. And why is that important? Then you see on the right, the narrative for cancer, which is optimism and hope. That's critically important. And evidence tells us that that's much more important in terms of supporting or effectively supporting people with behavior change and encouraging healthy behaviors. The narrative of obesity, which is pessimism, which is fear, which is unpleasant, what that actually leads to, of course, is frustration, despair, and anxiety. So that's really important, I think, and that's the way that our policies are framed. Here's that example. So the one on the left is from NHS, so that's what we have in England, and then Wales in Health in Wales. So in the top left, you'll see smoking, alcohol and drugs, obesity, contraception. Again, it's not a behaviour, it's an outcome. And then you see in Health in Wales, again, obesity over here. It should be over there with cancer, dementia, diabetes, mental health, and more. One of my last slides, again, this is something that I often do with policy makers, with politicians, because I really want them to really think about how important this topic is. Because unfortunately, they in many instances also think it's just a bit of teasing. It's, you know, it's not that important, and maybe some still think that it's important to change behaviour. So these are the different ways that you can be discriminated. So we have direct discrimination, indirect discrimination, harassment, and victimization. These are the four that's described in the Equality Act, which is the legislation, the law in the UK that protects us from being discriminated in the workplace or other settings. And if we take weight out of the equation, we think about weight stigma experiences, people are directly discriminated against. People are victimized. Children are victimized in schools. They're harassed about their body shape, their body size, and other. If we take weight out of the equation, what we're actually seeing is discrimination, and discrimination right across society. So if we want to highlight how important this topic is and how it may well be impacting people, sometimes taking weight out of the equation and really thinking, what are these experiences like? How is it impacting people can be really useful. This has been a useful way that I've engaged politicians on this topic. And finally, is really to say that where I started, which is a call to action, we all need to act. But that action is right across the system, from policy down to the individual level. So with policies, can we reflect on those policies? Can we make sure they're evidence-based? Everybody in this room is an evidence-based person. You're a healthcare professional. You would anticipate and you would expect there to be evidence behind policies that are developed. I was going to speak a bit more about some of the policies that you will be aware of. So soft drinks industry levy, so taxes on sugary drinks, labeling, and so on. We've seen that in the UK as well. Just to quickly say on those, I think they are very important from a population health perspective. I'm very supportive of those taxes. However, my view is that they are not obesity policies. They are policies that will impact the population. They will not necessarily impact obesity levels. And I think in all the countries where there have been taxes, obesity levels haven't decreased. And in many instances, they've actually continued to increase. It's a population health intervention. If we're looking at the key issues impacting obesity, those wider determinants and so on, that's where policies need to be developed. So I do think they need to be, these policies are needed, but for a population health perspective, not for obesity. And then just to finally say on that, when the soft drinks, the sugary drinks policy came in the UK, there was actually, it actually led to an increase in stigma, because it came in the Childhood Obesity Action Plan, which meant that people perceived it as, oh, I'm now going to have to pay more tax because of people living with obesity who are lazy, who are gluttonous. It's their fault that I'm now having to pay more money if I want to buy a sugary drink. So actually, it had an unintended negative consequence. We do need to address wider determinants and health inequalities. Health inequalities inevitably is a key issue here. Wider determinants, if you look at the single factor that is consistently highlighted as the most important relating to obesity, but you could say this, of course, for the long-term health conditions, it's poverty, it's deprivation. And we're not addressing that, and in many instances, the gap between the rich and the poor is getting worse. We need to create weight-inclusive spaces that mean that everybody of all body shapes and sizes can be part of that environment and part of those activities. Of course, we want fair, accurate, and respectful media portrayal. That seems obvious, but unfortunately, we don't have that. And the example I gave you is people just wouldn't accept disrespectful, stigmatizing rhetoric about people living with cancer or other long-term conditions. Why can't we have that for obesity? In schools, we need to ensure that policies include weight-related bullying and teasing, harassment. We now know that children report, the most common reason that children report bullying is related to weight status now. It's not about other topics. Weight status is the #1 reason that children experience bullying. Equality, diversity, inclusion training, maybe we can include stigma relating to body shape and size in there. We need to be able to support local actions, local narratives. It's critically important that we understand what's happening in the locality. We can't take interventions that have been really successful in Australia and then apply them here or somewhere else. We need to make sure that we understand the local context. And of course, you know, on that individual level, we need to be able to address biases that we have. We need to be big enough, strong enough to really reflect on the biases that we may have. The reality is that we're all exposed to stigma every single day, whether it's the media, whether it's things that we see on TV, whether it's interactions we have with our social circles. We need to be prepared to address biases that we may have ourselves. Just to summarize, and actually the image on the right really highlights what I typically see, is that when people become more aware of stigma and they understand how impactful it can be, a lot of people want change, but they're not prepared to make change themselves. And I think, again, we need to be prepared to be able to do that. It is a modifiable risk factor, as I've highlighted. Irrespective of body shape and size, experiences of weight stigma can be very detrimental for all individuals across all body shapes and sizes. It can impact the effectiveness of what we're doing in healthcare. And of course, we need to reduce that blame culture that's very evident in our society. The quote down the bottom really encapsulates where we are as well, from Desmond Tutu, which is, if you're neutral in a situation of injustice, and this is a social injustice, you've ultimately chose the side of the oppressor. So I'll finish there, and this is also a call for papers that you might have seen. We launched it yesterday with the Lancet Americas. So over this next 12 months, we're accepting submissions for research relating to weight stigma, specifically in Latin America and the Caribbean. So if you're already doing some work in this space, or you potentially can gather data on stigma in Latin America, then, you know, we want to hear from you. And it's great that, you know, the Lancet Americas have supported this topic. I think that, again, highlights how important this topic is for this region. There's a real lack of data on stigma in this region from an empirical perspective. But what we do know is that anecdotally, there's a lot of reports of stigma. There's a lot of reports from patient groups, for instance, who are reporting stigma in different spaces. So I think it's critically important that we get that local evidence. Thank you very much. That's me. Hopefully I didn't speak too quickly.
Eric, pode parar a gravação, por favor.